Arthur Cooper,
Yes.
and Dr. Schenker.
Yes.
Also unanimous.
That concludes the medical standards subcommittee report.
Thank you. QA committee, Dr. Redlener.
The QA and QI committee of REMSCO and REMAC met on a romantic February 14th, 5 p.m. by phone.
We're not sure what to see.
I didn't even get any flowers.
Yeah, sorry. I didn't get my wife out. No, I'm just kidding. Yes, I did. Yes, I did. So we discussed a number of items at the QA/QI committee. First of all, there was no cases that were discussed at that time. We discussed an ongoing project around naloxone data and presenting naloxone data to this body as a way to keep us informed about what's going on in the region. We plan to discuss, EMS data is being presented at the next interagency meeting and will be presented here, we hope, at the next REMAC meeting. The next item was the midazolam study that we've been working on for quite some time now. Finally, now that the website is up and running, you have all received an email with the request for data from Marie. Went out, I think, at the end of last week.
Went to agency medical director.
It went to agency medical directors, right? Agency medical directors, where there's a request for data. Data request is a 6-month period from July 1st, 2016 to December 31st, 2016. We wanted to just look at that set of data about standing midazolam for excited delirium protocol. So please look through your emails and find that survey. It is an easy to complete survey. It's not patient level detail, but you'll have to do some mild amount of analysis. So please get that back to us in the next, I think, what did we say, by the end of the month?
By March 7th.
March 7th.
And just, it went out to EMS leadership, not just EMS medical directors, so if you have not received it, check out your whichever EMS agency you're medical director for and tell them to forward it to you.
Thank you. So we will be looking at that at the next QA meeting as well. We've been thinking also for some time about a safety study in the region. However, given the most recent national information about fatigue in EMS, there's been a national study published by folks out of Pittsburgh and supported by National Highway Transportation Safety Administration with key recommendations around how to mitigate fatigue in EMS as an industry standard. So we'll be looking at that, and hopefully we'll bring some thoughts and ideas specifically about that to this body to discuss how we as a region can address the issue of fatigue in EMS, because we all know that it's there. There's evidence that this exists in our service, and we need to address it. The last item on the agenda that we discussed is on the board here. At a prior REMAC meeting, we discussed a case where for the mobile stroke unit, there was an intracranial hemorrhage identified in the field that went to a non-neurosurgical capable center, a hospital, and had to be transferred. We were concerned about the safety implications of this, and so working with the mobile stroke unit, medical leadership, and the fire department, we came up with some language for a REMAC advisory, which is on the board. I'll just read it and talk a little bit about the details. So the regional REMAC is responsible for REMAC New York City is responsible for developing, approve, and implement pre-hospital treatment and transfer protocols to use within the 5 boroughs in New York City. REMAC REMAC operates under the auspices of Article 30 of New York State Public Health Law. Upon review of the New York Presbyterian Mobile Stroke Treatment Unit patient treatment and transport decisions, a novel clinical scenario was identified that requires the development of specific guidance from REMAC. If a patient treated on the MSTU is identified by CT scan to have an intracranial hemorrhage, whether subdural hemorrhage, subarachnoid hemorrhage, or intraperitoneal hemorrhage, the MSTU care providers will consult with online medical control physicians to transport patients to a hospital with rapid neurosurgical consultation. Also, the recommendation of the QA committee was to add a line about identifying trauma centers as, regional trauma centers as the centers that these patients should go to, given the fact that neurosurgical subspecialty care is available at those centers. So this is what we'd like, this is what we're presenting, put as an advisory. It's a very limited scope, as there's only one ambulance, but this is what we're proposing to address this issue.
So it's David, and then we'll, any other discussion? Start with David.
Clearly, it's the right thing to do. Why are we detailing different types of hemorrhage? Why don't we just write intracranial hemorrhage? I mean,
We can.
I don't see epidural over there, right?
Fine,
It can be done that way, that's
Yeah.
fine.
okay, it's a good suggestion.
Any other questions, comments? Yes,
Is OLMC gonna have a list of hospitals that have neurosurgical capabilities,
So-
intervention?
originally it was written as an OLMC physician directed protocol. In consultation with Glenn and Michael and myself, I think we're gonna have the advisory specifically say to the closest trauma center. That simplifies things in that trauma centers are state designated. They must have a neurosurgeon on call, so that makes it very simple as opposed to the non-trauma centers, the comprehensive or thrombectomy capable or all those other centers, which unfortunately we'd have to go through a whole vetting process if we were gonna make an OLMC decision. And since we wanna implement this sooner rather than later, because it's really for one and eventually 3 units, it really doesn't pay to, this is something that we kinda have to get them direction sooner rather than later. So making it trauma centers as opposed to a online medical control physician determined the destination makes it a lot simpler. There will still be contact just for an information purposes, so they know where the unit is going. Glenn? you had
Yeah, we had, we'd gone back and forth, and I think that we were advised by the state at that Greater New York Hospital Association meeting about these comprehensive stroke centers, that they initially were not gonna designate, but they have decided to designate, but it's not gonna be at least until 2020, which probably means 2021. And as much as we'd like to say that there are quite a few facilities that are doing the thrombectomy, which would have a neurosurgeon and such, we would have to get a commitment from the CEO that it's 24/7, that it's, all these things are in place, that they guarantee us, that the list, I mean, in this day and age, not so far in 2018, but in 2017, we still have cath lab STEMI centers that will call us and say, we're not available for the weekend. So, state trauma, and that can happen to trauma centers as well if the CAT scan is down and things like that, but that doesn't happen as often, and they know that they need to get back up and running. So I think currently, having online medical control in place makes sense because the MSTU, the Mobile Stroke Treatment Unit, actually contacts telemetry, the physician, just to get approval to go to currently Cornell or New York Presby if they're not the closest stroke center. And then having that just consistent, we can tell that they were diverted because it was a bleed that they see on CAT scan. And once the comprehensive stroke centers, or once we start that project where we start bypassing primary stroke centers to go to these thrombectomy centers and comprehensive stroke centers, they'll be vetted at that point, but we
Correct.
could probably add them to that at that point. But right now, I think it's just safer to keep it that trauma centers are gonna have these neurosurgeons.
David and then Art.
Just a quick question, why are we specifically saying trauma centers? It's not written over, I don't see over there wording that says trauma centers. I
It
think,
isn't added yet, but it's
I
going to
think
be.
that what's more important is a center with neurosurgical capabilities. I mean, most of these patients actually won't have trauma, right, most of these leads?
Correct. However, trauma centers by state designation and verification have to have a neurosurgeon. There's no other way to verify that there's a neurosurgeon unless we go through an entire vetting process of that other facility.
And David, just to that point, we're thinking and planning to do this for our whole rollout around.
It will
regional
happen,
stroke
once
stuff,
we have that
But I
done.
think it's just, we wanna get this done quickly.
Okay, fair enough.
And again, it's one unit, but 2 coming on board, one
Correct.
in Brooklyn and Queens. So we're talking, it's not a protocol for the region. They are 911 ambulances, but they're not responding to 911 calls. They're not going to chest pain and cardiac arrest.
Yes. Art.
Are there any of the trauma centers that currently are approved for New York City not also approved as stroke centers?
Yes.
How many, do we know?
I think we figured out it was 2.
You mean that are comprehensive stroke centers and not
That
trauma
are,
centers?
the other way
That
around.
are trauma centers that are not stroke centers.
Where's
In other
this?
words,
Where's
in other words, you know, if you've got a patient that has a stroke, that has a bleed, you want a neurosurgeon available immediately, but you also want the stroke team, the neurology team available
Correct.
immediately. And I would submit that, you know, that both of those, you know, pieces should be in place. If you're taking a patient with a stroke to a place that has neurosurgical capability 24/7, which I agree, you know, is most likely to be the trauma center.
Joe, I think that there's the primary, every trauma center is a primary stroke center, right?
Correct.
I don't think it's
Comprehensive.
comprehensive
You know,
stroke center.
that's my question.
Yeah,
That's fine.
primary stroke center, yes.
Yes, Dr. Winchell.
So, just to be sure I understand your intent here, they're going to make a decision along with medical control whether they're diverting based on hemorrhage, or they're gonna do it with any hemorrhage?
So in the event that upon scanning these patients, they find an intracranial hemorrhage, because the stroke ambulance has the CAT scan on board, they find an intracranial hemorrhage, to go to a primary stroke center would be detrimental to the patient. So instead of going to a primary stroke center, they're gonna go to the closest neurosurgical capable center, which currently we're gonna use the trauma centers, because we know that they have to have a neurosurgeon.
And that's for any intracranial hemorrhage from 1 micron to 5 centimeters.
I think that the patients that will have a CT scan in the field are very limited, and the numbers will be low. But yes, I would say that probably
would be anybody
we
that
wouldn't
they
wanna
find
di-
to believe.
You probably wouldn't want to dissect it down too much. I would say just leave it as.
I think
guess
we're,
who's reading the scan for the bleed?
so they're read by 2 people. They're read by a neurologist who is either connecting to the ambulance via telemedicine, or a neuroradiologist is reading it as well.
I just want to be clear once again that the trauma centers all have the immediate availability of neurological response, correct? I'm
Yes.
not talking about, invasive procedures. I'm just talking about,
Primary stroke center.
primary stroke center.
I'm 99% sure we can go
Yeah.
back and then confirm
I
that.
think that should be
That
confirmed.
is true. That is confirmable. I went through the entire list. Every trauma center is at a minimum a primary stroke center.
Okay, so long as that's true.
Yes.
Just,
David, and then
just,
Paul.
in response to Dr. Winslow's question, we have to remember that these are smaller CAT scanners, they're 8-slice CAT scanners, so their resolution by definition is gonna be, lower, so if they identify a bleed, it's gonna be a significant bleed.
But my point being is you have someone with some knowledge
Yes.
interpreting the scan, and so if you wanted to make a more detailed protocol or utilize their judgment in terms of making the decision, that I think both of those make sense.
Correct.
Question, do they CAT scan, ever CAT scan after thrombolytics?
Their policy is not right now. They're not doing a CTA or anything
But
else.
if they identify a bleed after thrombolytics, they're gonna go to trauma center now?
Well, they have identified some that bled, but that's not until after the repeat. There's not enough time for that.
The repeat would be, the
Rather than
repeat
having
scan
time
would
to
not
sit
be.
there. It's a follow-up CT that.
Only if they clinically change social.
No, they wouldn't repeat the scan on the ambulance.
They
They
don't.
repeat it
That's
when you
the
get to the
bleeds that they
hospital.
found that from the TPA itself was after the fact. I believe the repeat.
Yeah, Paul?
Bleed rate is about, 8 to 10% of all strokes?
That's 6.
Okay.
Just a quick corollary. How did we get a protocol through that didn't have an out plan in place for almost 10%, 8 to 10% of the existing? What else are we missing on this protocol? I think this is an interesting discussion and corollary, that we rolled out a unit that we didn't know what to do with it with all 100% of the patients it was going to take care of. And I would caution all of us in the room that, you don't launch a missile or a space shuttle and then say, well, what happens if something breaks? I think we all owe a lot more dedication to these types of programs in the future, which now they're going to be in triplicate, that there's things that were clearly left off that were possibilities that now we have to go back and fix. I have nothing else except a statement about this.
Well, just, strikes me that if
we're not worried about inappropriate management of small bleeds. But that same scan is being used to inform the decision to give TPA. Isn't that a contradiction? I mean, I'd be more worried about giving TPA to someone with a bleed that doesn't show up on this 8-slice scan than I would be the other way around. Just a thought.
Any other comments, questions, discussion? That's look, that's right, that's a good point. Honestly, I don't know what the scanner's resolution is. If David says it's 8, I don't know what it is, honestly. But again, they've been doing this, they've been using it around the country. This is not a new program to New York City. And it's already approved, so we're not even discussing that. We just identified this issue that we need to have some plan for them. So that's where we're up to. All right.
Where are we placing this? Where are we?
This is an advisory. It's just gonna be sent out as a regional advisory.
But we're not at the point yet where we can send this out.
This is the language that I'm just gonna write up and give to you if we approve it here at REMAC. I mean, it's not, what? Right, so our parliamentarian feels that there should be a roll call vote, so we'll do that. So
We have to add the language about the.
the language will be changed to include, to remove, it'll just say intracranial hemorrhage, we'll remove that first line describing the different types of intracranial hemorrhage, and then, the bottom line will read, will consult with online medical control physician to transport patient to the closest, regional trauma center. Any questions? All right, Marie?
Okay. Okay. Yes, no, or abstain? Robert Winchell,
Yes.
Christopher Graciano,
Yes.
Cindy Baselos,
Yes.
you and I have to have a conversation after the meeting.
It's 3 different
no
times
problem.
now.
Dr.
It's 3 different
Gonzalez.
ways.
Yes.
Yeah,
She's 3 different.
be nice to me. Dr. Acedas?
Yes.
Dr. Flownbaum?
Yes.
Michael Redlener?
Yes.
Peter Wire?
Yes.
Paul Barbara?
Abstain.
David Benelli?
Yes.
Timothy Stiles?
Yes.
Charles Martinez?
Yes.
William Fisher?
Yes.
Robert Krupe?
Yes.
Arthur Cooper?
Yes.
Okay, we have 1 abstention and 15 yeas.
Okay,
Which carries.
great. Dr. Redlener, anything else from QA?
There was one other item, which is that it was identified by the committee that we are interested in looking at how to evaluate online medical control facilities. And we'll be starting to look at the language that hasn't been reviewed in quite some time to develop potentially some program to look at, I don't know about recertification, but looking at the quality of online medical control. It will be headed by Dr. Joe Schenker.
You're talking about recertification of the facility or the individual?
The facility.
Facilities.
Okay, thank you. Training and education, Mr. Lax.
Training and Ed, so Training and Ed met last Tuesday by conference. We had it on a conference call. So there are several items that we've begun reviewing. The advisory that was sent out for the IAMP epinephrine, so we're developing a training module, an online training module that should be able to be used generically. Really the overall goal of any training that Training and Ed is going to be producing now is to help standardize regional training. So when something comes out of any one of the committees here, whether it's REMAC, QA, whatever committee it may be, CNC, the training that is generated by Training and Ed should be able to be utilized by both providers and agencies, and will be generic. So you don't have multiple agencies out there creating their own training programs that might overlap or even slightly conflict at times. You have one standardized venue to go to. Anytime there's a hands-on component, a canned package will be sent, without supplies, of course, to the agencies that they can utilize internally to train their providers on the hands-on portion. So that's what we're doing with IM Epi. We were looking at the hemostatic dressing idea. I know that REMAC approved that, if I'm not mistaken, recently.
Yes.
Okay, so we were looking at that. We have not found anything generic that is out there that we can send out regionally, especially since there are multiple possibilities of dressings that can be used. So for now, we're still looking into that. We did begin to review some of the old criteria that was set to select regional faculty members and program coordinator criteria, which is it's outdated. They're in shorthand, which leaves us somewhat short for faculty that's out there to provide instructor classes, to make more instructors in the region, which also are in shorthand, including instructor updates, which instructors all need as venues. That's the instructor version of CME. So we are working on cleaning up that criteria and sending that up to the state, so that they have more from us, and so that we can make more of those. Is there anything major that I'm missing out of that? I think those are the biggest things that we're working on.
Yeah.
We attempted glucometer. I think we need to clean that up. I think that's out there, but we need to fix it up and get that out so that we have something.
Well, we have a glucometry LMS.
Right.
It's there.
I think that we might have to change the platform on which it's rolled out because there were issues accessing it. So we're going to correct that. That way, there's something out there that everybody can get a hold of, and that's pretty much where we are at for now. One thing that we were looking into was to see if there are REMAC physicians that are interested in writing journal CMEs that we can somewhat mirror what the fire department is doing, although we do have a representative from the fire department that is on Training and Ed now that will help us collaborate with them. And by the way, they were very, very useful. You can thank them. I'll thank the Academy again. They've opened up the Academy and the resources there, especially the opportunity to video, create a lot of videos for training, which is something that's going to be huge for especially training that's going to require a lot of hands-on. So that's really big, and so we appreciate that. So in that respect, I think that's the next subject item that we had.
Yeah, I think that's it. And the fire department rep also was going to help us with hemostatic dressing.
Right,
They have
they're gonna see
some
what they
canned
have on
training.
it, but I think that they moved from one specific hemostatic agent to another recently, if I'm not mistaken, so whatever they had for the one that they were using, so that's somewhat in limbo for us, so.
Thank you. Okay, regional council update, Dr. Krupi.
Yeah, we looked at 2 training centers that came up for a vote with a recommendation not to approve.
Yeah.
And we concurred in giving that recommendation, so they were not approved. I don't recall,
That's because our last REMSCO meeting was, we couldn't meet because we didn't have a quorum.
Right,
So
right.
your report was already given at the last REMAC meeting,
Excellent.
so you don't have to
Even
remember
okay,
anymore.
good.
CMAC
Took me a second
update,
to
Dr.
remember.
Langsam.
It's not there, and perhaps Marie can report.
Marie,
What-
Art?
what- I can report, there
There was
was no
Nancy.
CMAC report.
Oh,
gave
no
us-
There was
quorum.
no quorum for
Excellent.
CMAC or the SEMSTO.
Sounds great.
No, but
Oh,
Glad I wasn't there.
yes, it did, Jim.
Glad I wasn't there.
There was a quorum for the CMAC, but it
My
was.
fault, there's no quorum.
CMAC reported, the CMAC must report to, must report to the SEMSTO before it's official.
Ah.
So although
So there is no
CMAC
report.
met, there is no.
Excellent.
We did-
Okay,
Next meeting will be in May.
We did give a report at the January REMAC meeting of what had occurred at CMAC.
fine, great. Okay, next, under unfinished business, the stroke tag, which we formed about 2 years ago, has been meeting and working with Greater New York, American Heart Association, and Mission Lifeline working on a regional stroke program and plan to kind of incorporate comprehensive stroke centers into our system. The meeting was held on February 1st, and I'd like Dr. Redletter to report about that.
I'm already talking too much this meeting, but I'm very happy to announce that we had a very successful regional stakeholder meeting in conjunction with AHA, Greater New York Hospital Association, the fire department, and REMAC. It was over 100 participants. We discussed regional plans that are based on the plans that we've discussed at this body, and there was widespread approval with some minor changes really to some of the protocols and ideas and thoughts behind it. There was also an update from some national experts related to the new data that's coming out about extended windows for interventional stroke treatment based on the FUSE 3 trial and the DAWN trial, which suggests that up to 24 hours may be beneficial for patients who receive thrombectomy if they meet certain criteria. Many of these items were discussed. There was some protocol change. The proposed protocol was commented on by this group of neurologists, emergency physicians, and EMS physicians. And what we hope to do is bring that protocol back to the protocol committee once we've kind of finalized those recommendations, so that it can be discussed on the EMS level and then presented at this committee. I'd also maybe like to give an updated presentation about what the proposal is, or what it's, where it's come, so that we can just continue to work towards building the system of care.
Maybe we can do that in the March meeting?
Sounds good.
Great.
Okay. I would just invite everybody, so that there's two groups, there's a pre-hospital group and an inter-facility group. If you weren't at the meeting, we still want people to participate in these groups, so reach out to myself or to reach out to me, and we can get you connected to participate in these ongoing discussions.
The meetings we'll be having, the pre-hospital group and the inter-facility group will be having alternating conference calls to continue their discussion and the planning. So.
I'll update everybody through Marie.
Okay, thank you very much.
Thank you.
Under new business, just, again, I think we've said this before, but to save the date, May 2nd to the 4th is the NSUC competition at the Rock, and if anybody wants to be involved or to learn more about it, please contact Dr. Isaacs. And that concludes our meeting. Any further new business? Any further discussions, questions? Marie?
I just want to remind that EMS week is the week of May 20th. We'll be having our EMS recognition night on the 21st, and we are looking for recommendations or nominations for EMS Provider of the Year, Physician of the Year. There's a whole list of them. Go onto our website. Many medical directors here for agencies. Hopefully you can find one of your providers that would be, worthy of getting an award.
All right, I will entertain a motion to adjourn.
Motion to adjourn.
Thank you very much, everybody.
Yeah, sounds good.
The next REMAC meeting, by the way, is on March 20th, if anybody was curious. March 20th.
Okay, that was good. Yes,
Oh,
definitely.
yeah, that's right.
Yeah, we're talking to Gary.
Jerry Rick did also, that's why I opened my notes beforehand, and I was so limited that it was prior to our last meeting, so we kind of built a gap.